Hey, Mike.
Hey, Chad.
Everything go okay? You get the leg back together?
Yeah, it's all patched up.
Lovely. Cool. I'll let you take it away. I'll introduce you guys. I guess you could probably introduce yourself, if you.
Sure.
Just so you know, Allie's recording. Is that okay with you?
Yeah, that's fine.
Okay. Thanks.
So, Chad, I want to thank you for inviting me to give this talk. I should ask first, is my first slide up? Does it seem like it's working?
Yes, I can see femur injuries for the ski patroller.
All right, awesome. And it's filling the screen appropriately. It's the right size and all that. So I don't recognize any of the names on the list other than Chad. I was a Sugar Bush ski patroller from 1988 through around kind of on and off through the 90s. I worked in the clinic when I was at UVM, so I'm familiar with the mountain and at least how we did a lot of the stuff back then. So it's an honor to be able to work with you guys. I hope to be spending more time at the clinic there as my kids kind of age out of high school sports and stuff. So thanks for this opportunity. I put together some slides. They're hopefully a guideline to inspire some thought and questions, and no stupid question if anything comes to mind. I don't mind being interrupted, but there should be plenty of time at the end as well. So if you think it's a quorum, Chad, I'll just jump right into it. All right, so topic for this evening, femur injuries for the ski patroller. Is the sound okay? The room, I'm kind of sitting in a big room. You guys hear me all right?
Sounds good.
Okay, good. So disclaimers, most of the photos in the talk I borrowed from other places, so they're not mine. And like I was saying, the goal of the talk is to stimulate thinking and questions. If I stray away from what is NSP or Sugar Bush protocols, stick to what you've been taught. Maybe think about what I say, but don't take bad advice from me. So what I hope we're going to come away with is, why is the femur important? What are some fracture types to know about? What's the initial management for you guys, or really anywhere else? What happens later after the patient's out of your hands, off the mountain, at the hospital, where I'm at right now? So the femur is that big bone in your thigh. It starts at the hip joint, comes down the thigh, ends at the knee. It's the strongest bone in the body, typically the biggest bone in the body, and it's usually pretty difficult to break it. So if you're dealing one that's broken with one that's broken, you got to keep in mind that it probably took quite a bit to make this happen. So just this applies to really lots of different things on patrol or first responder situations. So as you're coming upon the scene, you want to learn as you approach what are the hazards that you observe? Is there a trail of debris that gives you an idea what might have happened, what the energy level of the event was? There may be bystanders who saw what happened and are there to tell you what happened. Your future patient or accident victim may be able to tell you what happened. So we're thinking about level of energy involved. Are there additional risks that may be risks to you or to your patient or to the bystanders? Is there a potential risk from fire? Are there electrical wires? Is there chemicals involved? Is there fuel spilled? And I'm thinking about, the power cable on the lift tower. I'm thinking about snowcats and fuel and other things like that. Is there danger from above? Is there another skier just about to come off that knoll that doesn't see you and land on you? So assessing your scene, making sure that you and your patient are safe from additional trauma. Particularly dangerous is if you're out of view from where all the other skiers are coming, potential for additional collision. So that pair of cross skis above the site, maybe a coworker or bystander that's further up the trail telling people to cool their jets or maybe pick a different route. In the extreme circumstance, someone else from the lift shack might be closing the trail. There's some special things about race courses that we'll talk about in a minute. So I guess we're talking about race courses right now. So if you're working on a race course, there's a thing called start stop, and it kind of doesn't make sense at first. What they're talking about is that there will be no further starts of racers going down the course. So the reason that's important is you don't want to get out on the course and be run over by a 70-mile-an-hour or 100-mile-an-hour downhiller. So making sure that there's no further racers starting onto the course. Then some courses will have multiple racers at a time. So you want to stay out of the way until the course is clear of these high-speed trauma machines that want to run you over. So as a race physician, I'm taught to never go on the course until I see the ski patrol go down the course. So I'm counting on you guys to make sure that not only is there a start stop, but the course is clear and it's safe for me to proceed. So this femur, I'm telling you, it's a strong bone. So what are we really talking about? So how much force does it take to break a femur? I read there was 4,000 newtons on average to break a femur. And I don't really think in newtons. So 1 ton is 9,800 newtons. I have a 5-ton log splitter. So that's kind of gives me an idea of a lot of newtons. I could break the femur a few times in my log splitter. If I want to break an egg, it takes 25 newtons. So that's way more than breaking an egg. I found this little factoid that crushing a skull is 2,300 newtons. So 2 skulls are about one femur. But really the point of this is if someone sustained 4,000 newtons to their femur, their skull is at risk, their other organs and parts are at risk. They may have been exposed to similar amounts of force. So what are some common causes of femur fractures? Probably in our society, the most common cause are auto accidents, cars versus pedestrians, high speed or high energy bicycle crashes, sometimes sports collisions. I've taken care of water skiers who had bad crashes and had femur fractures, falls from a height, off a ladder, off a cliff, out of a tree. And then there's the category of folks out there with pathologic bones. So when we hear pathologic, we might sometimes think tumors and illness, but really as we age, most of us are going to develop osteoporosis. So osteoporosis is in sense a pathologic condition that makes our bones weak. So a large portion of the ski area visitors are becoming in this age group. So similar to any other injuries that you may encounter, you want to start with your primary survey. If there's no airway, breathing, and circulation, you don't really need to worry yet about the extremities, but we want to kind of stick to our protocols. I got to turn away for just a second here. I'm still in the operating room. I was telling Chad we were just working on a femur and finishing up some of my documentation there. So don't forget about oxygen. Even if you think, well, gee, it's a leg I'm working on, this patient may have other things going on. To really support their overall condition, I would advocate liberal use of oxygen with awareness of the distance that you may be away from definitive care and supply of oxygen. You don't necessarily want to run out if you need it later, but awareness of the potential benefit of oxygen. You want to, once your ABCs are established, assess for whether it's an open injury or not. Is there ongoing blood loss that you can see or feel? Even closed injuries, though, can hide a lot of blood loss. There's a lot of room inside the thigh and other compartments of the body. So from blood loss, what we're really kind of concerned about is the potential for shock and secondary and distant organ damage and the overall stability of the patient. So external hemorrhage, we want to identify it, don't miss it. Start with consideration for direct pressure, elevating the extremity. Any wound that's accessible may be amenable to packing. A windlass bandage that kind of pushes your packing in providing direct pressure. Then you think about indirect pressure if you're not succeeding with the direct measures, finding a pressure point and applying pressure proximal to the wound. A tourniquet is a viable option in a lot of circumstances. You want to at least be aware of the distal neurovascular status after any and each intervention. So if I put pressure on a wound and the pulse goes away that used to be there, I might change the way I'm doing it, depending upon probably the amount of bleeding and whether I feel like I'm succeeding caring for this patient. So traction, it's something that we use often. I was using some just now today in the operating room. So we're doing it for similar reasons out on the hill, but why do it? So if bones are overlapping, you think about it, your thigh and your femur is sort of meant to be a certain length. If it breaks and the bones are overlapping, all of a sudden there's this extra space inside your thigh. And what's going to fill it up? It's going to fill up with blood. So if we pull the leg back out to length, it makes a little bit less space for extra blood to accumulate. The blood that does accumulate comes up to the pressure that kind of equals or comes close to the new blood arriving. So the additional blood is tamponaded off and doesn't accumulate so quickly. So realigning the limb limits the volume available for bleeding. With femur fractures, we're very often going to be using a traction splint. There may be other circumstances where box splint or other apparatus is preferable. Secondary survey, we talked just a little bit about reading the wreckage. It's often helpful to take another look around once things are sort of starting to cool down a little bit. There may be other things you didn't notice. That dead limb over your head that's about to fall and crush everyone there. You know, just what are your surroundings, or is everyone there still safe? You want to gather as much information as you can from the patient while they're conscious and with you, assuming they are. What are their allergies, medical problems, past history, last meal, and And like I say there, the patient's ability to participate may be temporary. Bystanders have a way of wandering off. So if there's someone that saw it, they may have reasons that they don't want to be there and leave. So talk to them while you have them. Extremity evaluation. People talk about a look, a feel, and a move. So first, this is what I do. I look at the part. Is it pointed the right way? Is it the correct length? Is, the foot pointed forward? Is it to the side? Is it in? Is it backwards? And then I feel the part that I'm suspicious of. Does it feel normal? Is it crunchy? Are there little broken bones inside it? Is it squishy? Like not like muscle, but like blood or hematoma. And then the patient participates in this. Does it hurt when I touch it? Ask the patient, can you move it? Do your toes wiggle? Are you able to lift the leg up? Or, if it's another extremity, are you able to lift the arm up? And if they can, great. They're going to show you. If they can't, that's okay too. You're learning about their injury. Does it hurt when I ask you to try to do these things? If you can't move it, what if I gently just move it a little bit? If it hurts, they're telling you there's something real going on. If you're able to move a part all around, it's probably a lesser injury, but listening and learning. So we're out in the cold and the snow, and we're worried about frostbite and precipitating shock by exposure to elements. So you want to have access to the injury, but not overdo your exposure to the elements. Often you can sneak a peek through a zipper or up a pant leg, certainly after asking the patient's permission, down the pant leg, up the pant leg, without necessarily totally exposing the extremity to the elements. Identifying an open injury is important for a few reasons. A blood loss situation increases the urgency. Open or complicated injury is ultimately going to end up at a higher level of care situation. So kind of realizing the need of the patient early in the process is helpful and maybe life-saving. Pain, analgesia. So there's a lot of attention to trying to make people not suffer excessively, but we're also in an era of caution about narcotics. And I'll ask maybe later for a little feedback from you guys, who has what pain medicine with them in Vermont in this day and age. But oftentimes splinting or immobilizing or even applying that traction provides great relief to the patient. So the basic things that you want to do are going to help with pain management. A broken part that's flopping around hurts way more than a broken part that's held still. So emphasis on stability of the part. Chad's messaging me that the ambulance has nitrous. So that's an example of an inhaled pain medication, which can be tremendously helpful. If you're traveling out west or overseas and come across an injury, you may have people show up that have syringes of narcotics or other things that they're prepared to give to athletes or other folks they know. My kind of basic sense is we don't want to get mixed up with things that we're not quite sure what they are. So I would work hard to avoid needing to give medications on the hill, but 2 cents worth. Immobilization. So the box splint is a super effective thing for extremity injuries. SAM splint that you guys probably have in your patrol belt or in a backpack, real helpful. Talked a little bit about traction splints. They're kind of the workhorse implement. The backboard can really stabilize a lot of stuff, used either independently or in concert with some of the other splints. So are there paramedics on the Sugarbush Patrol that have access to and are authorized to use some of the stronger pain medicines? All right, so a day may come where that's available locally. All right, so other kind of special situations, crush injury. And what I'm thinking about is, did a rock fall on you, tree fall on you, snowcat get you and eat your leg? So crush injuries, part of the reason they're important is there's muscle damage. The damaged muscle releases all sorts of nasty chemicals into the circulation, causing electrolyte abnormalities, acid-base abnormalities that your patient is then challenged with. Rapid access to fluid resuscitation seems to be pretty important with crush injuries, so kind of keeping that in the back of your mind. Compartment syndromes are a special situation where if you think of like a hot dog that you're cooking on the grill, your muscles have a wrapper, kind of like the hot dog. So the insides of the hot dog are a certain size and volume. If you pump a whole bunch of swelling into a confined space like a hot dog, it wants to pop open or explode. Well, your muscle fascia is strong enough that it's not going to pop open or explode. So the inner part of the muscle gets damaged or destroyed by that increase in pressure. I'm not very good with a mouse. Sorry about that. Fat embolism is a phenomenon to know about where the marrow contents of your bone, typically a bone that's broken, some of the fat that's in the marrow breaks loose or is introduced into the circulation, and it can go to the lungs. It sometimes shows up under the skin. In the axilla is the classic description. It'll sometimes be visible around people's eyes. It can interfere with oxygenation if it goes to the lungs. It can interfere with your brain function if it goes to your brain. So it can be a pretty nasty thing. So awareness of these special considerations that may make you think quicker about transportation to a definitive care situation, trauma center, ambulance, helicopter. Those are the things to be thinking about. I came across what I thought was kind of a cool flow chart, and I'm happy to share it with anyone that wants it. But just kind of the things that we were just talking about, you can kind of glide through this algorithm. So what I thought was most interesting, though, was if it's open and bleeding or there's a problem with the pulses. So blood or a problem with pulses, we're urgent transfer to hospital. If there's pulses and it's just kind of a not good, screwed up extremity, we're still transferring to the hospital. So we're doing our assessment up top, we're doing our mobilization, and we're getting these folks transferred. So I'm going to take a deep breath here. We have, I'm in a room just like this right now. I'm not smart enough to know how to turn my camera on and off to show you where I'm at, but suffice it to say, it looks a lot like that room. And I thought we might just run through some of the injuries that I see, have some x-rays and some thoughts on things. So I'm going to start proximal and work distal. So we're starting up back to our femur. The way I think about the femur is the round part up here is the femoral head. There's a part called the neck that attaches the head to this other part here called the intertrochanteric area. This lump here is the greater trochanter. This is the lesser trochanter. So this area is intertrochanteric. Just below that, it's below the trochanter, so we call it the subtrochanteric femur. This is the femoral diaphysis or shaft. The transition from subtroch to diaphysis is called the metadiaphysis. This would be the proximal metadiaphysis. Right above the end of the femur is the supracondylar femur. The lumps on the end of the femur are called the lateral and medial condyles. And, really any of these parts can be involved in a break. So kind of having a sense of the names of the different parts of the bone improves your ability to describe what you think you may be dealing with. So just orienting, this is the pelvis up here. This is the femoral head. The socket, we call the acetabulum. So the femoral head is sitting in the socket. There is a break across the femoral neck. So it's above the trochanters, lesser trochanter, greater trochanter. This is more common in an elderly person or advanced stage or osteoporotic person, but can be seen for sure in high energy situations in young folks. In a young person, it's treated as a surgical emergency. This break disrupts the blood supply to the head of the femur. If it's ignored or delayed to be treated, even if it's treated in such a way that keeps the femoral head often doesn't survive. So there's felt to be a window of opportunity to restore alignment and get this fixed promptly if it's a person who's otherwise well and young enough to do that in order to save the femoral head. The way that you would do that is in an operating room, you use traction and realign the bone and fix it, typically with screws. There's a variation on the compartment syndrome concept that I talked about. When this breaks, there's bleeding into the hip joint capsule, which is a space of limited volume, and that bleeding can increase the pressure and snuff out the blood supply to the femoral head. So what a procedure called a capsulotomy is done along with these screws to open up more space for that blood, release the collected blood, and hopefully that femoral head survives by doing this. And this type of fixation is used if the bone isn't too far out of place in older folks, but in a younger person, after it's lined up, if they're in a sense too young to have a replacement, this would be the treatment of choice for that fracture. Folks that are older and potentially somewhat lower demand with that fracture will be treated with what's called a hemiarthroplasty. So this is essentially a one-piece implant that doesn't move. We hammer it into the hollow of the femur after it's been prepared. We select the size of the ball to match the patient's size, and then they keep their own acetabulum or socket. They're able to move this, it's usually metallic ball, around in the socket, but that's the way it's treated in a lower demand older person. In a person that's active who might have arthritis or previous hip symptoms, a total hip might be a good answer. So there's an acetabular component, a metal socket that we hammer into the person's pelvis. There's the pelvis up here. Their bladder would be over here. Thigh is down here. Then we hollow out the top of the femur, hammer this piece into their femur. It's called a femoral stem. And there's adjustable length heads that would go on the stem to get the length and stability right. But this is a good answer for higher demand older people who may have some arthritis before the injury. Just moving a little further down the bone, this is what an intertrochanteric hip fracture looks like. So the break involves the lesser trochanter, the greater trochanter, and there's often a separate piece that's the neck and a separate piece that's the shaft or diaphysis of the femur. So I routinely fix those with an implant like this. So there's a screw that goes into the head fragment. It goes parallel to the neck, and then this rod or nail goes into the diaphysis. It's hard to see on the x-ray, but the rod has this hollow spot that the screw goes up through. So when the person steps and puts their weight on this, the screw has the ability to glide or slide within the hollow of the nail, so the fracture is being compressed and encouraged to heal while they're up walking and putting weight on it. This was the surgery I did earlier this afternoon. This is a different implant that tries to do the same thing. So this person has an intertrochanteric hip fracture. There's a plate that's secured to the side of the femoral diaphysis, and that plate has this hollow barrel where the screw is free to slide within. So the screw attaches to the femoral head. When the person steps, there's force through the screw, and that screw is allowed to slide and compress the fracture and stimulate healing. Moving further down the femur, this is a shaft or diaphyseal fracture. And check it out, like we were talking about, look at all this kind of potential extra space that didn't used to be there for blood to accumulate. If it's higher energy, there may be more parts. So bonus question, anyone want to throw out a description of what you might call that? I can't believe we have a shy crowd.
Comminuted?
So, comminuted, love it. That's exactly what I would call it, a comminuted diaphyseal femur fracture. Sometimes these pieces that are sort of triangular get called butterfly fragments. They look a little bit like a butterfly. So this can be kind of a challenge. It's a jigsaw puzzle to put back together. The good news is that because it's not a joint surface, you don't have to get all the parts exactly back in the puzzle where they go. You really just have to attach the femoral head to the distal femur in a way that is similar to the person's other side. And most of the time, your body is going to fill in the little gaps. So in the US, that is typically treated with an intramedullary nail. So the way this is done is, again, with my friend Traction, in the operating room, we pull on the leg, we get the parts kind of lined up, and there's a skinny little wire we send using a video x-ray machine down inside the bone until we have it all the way down here. Then we use these cannulated reamers. So they're kind of like drill bits that are hollow that the wire fits in the hollow. So you start with a small one, you send it down the wire, making space for the size nail that you, for a variety of reasons, deem appropriate. And you go up a millimeter at a time, drill after drill, reamer after reamer, and then you slide this nail down over the guide wire, getting it in place. Oh, I'm sorry about that. Jumping the gun. So then that secures your fracture, but you don't want it to spin around and be floppy around the nail. So it's typically fixed with 1 or 2 screws at the top and a couple of screws at the bottom so that it can't spin on the nail or rotate. If we move further down to that supracondylar or intracondylar region, this is an example of a fracture at that level. This, I thought, excuse me, was just a cool photo of, this is a CAT scan that has been formatted into a 3-dimensional reconstruction. If I was better with video, we'd be able to spin these parts around and look from the front and the side. And when you're planning on fixing it, it's just nice to know shapes and sizes and sort of where all these pieces are supposed to go. So a fracture like this, we often are treating first with a whole bunch of screws securing the distal or right above the knee piece together, and then a plate that goes on the lateral, typically the lateral side of the femur, to line it up with and attach it to the diaphysis. So because these pieces aren't part of the joint, we don't really need to mess with them too much, but we want to line the knee up properly in its relationship with the rest of the thigh. Simpler patterns, we can just slide a nail or a rod up inside there to do the same kind of thing, attaching it below and above the fracture. So again, taking a deep breath for a second. It all goes back to our basics, though, our initial patient assessment and then our extremity assessment. So without the ABCs, we don't need the extremities. But once the ABCs are secure, we're moving on to distal sensation, motor exam. Can you wiggle the toes? It's often a judgment whether a ski boot ought to come off here or somewhere else. I would almost always leave a ski boot on. Is there an open injury? Are you able to reasonably look for bleeding? Is it warm enough? Is the patient okay in the location and environment? Is there a side zip pants? Use your eyes and your hands to peer around corners. Rapid assessment of what you need for supplies. What's the help you need? Get another patroller, get the sled, get the oxygen, get the backboard. Think about transport. So what's important about this? Why even spend the time talking about femur fractures? The main take home is a femur fracture can kill you. So we want to not fool around with these. So just kind of thinking about it, how do femur fractures kill people? In the short term, really two ways, I think. You bleed to death either from an open injury or a closed injury that accumulates blood in your thigh, or it's the associated injuries. It's the head injury, the pulmonary or cardiac or intra-abdominal or pelvis injury that gets these people. So if we can do a nice quick job of taking care of the extremity, it lets us take care of other things. So blood volume, average male adult, somewhere around 5,000 milliliters. So when I was on the ski patrol, we measured most things in how many cans of beer would that be. So 354 milliliters is 1 can of beer. So what's that, like 20-ish or 18 cans of beer, something like that, fit inside your thigh. Thigh with femur fracture will hold 1,500 to 2,000. So that's a large percentage of the total volume that all of a sudden is in the thigh. Open fractures, the blood's coming out of the person, so rapidly you can lose even more. So think about shock. What is shock? It's not enough oxygenation to the tissues. The oxygen comes from the blood, so if the blood isn't in the patient or in the circulation, we're headed towards shock. There may be early signs that your patient is headed to shock: tachycardia, hypotension, decreased pulse pressure, decreased mentation, decreased temperature. Results of this shock may be acidosis or a change in the pH of the patient, hypothermia, coagulopathy or inability to clot lacerations or injuries. And then there's distant organ challenges, kidneys, brain, and so forth. So we want to avoid shock. So how do we measure our success? So we should try to achieve a rapid assessment of the patient and including the extremities, expedient mobilization, and safe transportation. So thanks for listening. Village of Zermatt in Switzerland there on the right. And I'm more than happy to field any questions or comments or what have you.
Hey, Mike.
Man, Mike.
Thanks for
Go
the
ahead.
presentation. This is Matt Holland.
Hey, Matt.
Is internal bleeding from the femoral artery almost always going to be evident if it's significant? Like being able to see, the hematoma from the outside if bleeding is there. I mean, of course, we monitor CMS at the extremities, but how much can you tell? I mean, is it always going to be obvious?
No, it's really hard to tell. Yeah, that's a tough one because people can be bleeding a little bit on and on and on, and can sort of creep up on you and be noticed late. So I guess I would advocate constant vigilance for it, but it's one of those things you just got to keep checking and rechecking. That's why we follow the vitals and repeat our physical exams for distal pulses whenever there's a change, or after splinting, after transporting. And yeah, so constant vigilance is really the answer. If you have an open injury, you may notice blood spurting right away, but no, that can be a hard thing to see.
Hey, Mike.
Yes.
Pete Sarisky here. First of all, I remember you when you patrolled, so nice to see you again.
Good to see
so
you,
as a first responder, the big question we have to ask ourselves is, do we put traction or not? And, I've heard it's the third rule where it's, the middle third of the femur, you apply traction. If it's closer to the hip or the knee, you don't. I've also heard you measure like a fist, the patient's fist width from the knee versus the hip, and if it's not that, then you have tried traction. Can you just go over a little bit about the decision-making tree for traction versus not, and the best, do you err on the side of caution? Do you pull if you're questionable? Do you not pull? I mean, just some thoughts on that.
Yeah. So first of all, the standard teaching is that kind of the middle part of the thigh, you're gonna use traction. If it seems to you that it's too high or too low, the standard teaching is that you should not use traction. I have, excuse me, yet to see, in my personal experience, I've yet to see a hip or knee injury that was made worse by a traction splint. So my personal experience may have biased me, but I encourage you to follow the standard protocols and apply traction only when your protocol dictates it. So the kind of the middle part of the thigh is when traction is standardly accepted. But you just heard me tell you that when the proximal femur fracture comes to me, I use traction in its treatment. So I think it's hard to tell without x-rays what the traction is really doing to the bony injury. So because you guys are using physical exam to decide what the person might have, it's safest to stick with the protocols. So whatever you do to hold the injured part still is going to be somewhat helpful. So if you're not sure and opt not to use traction, I really like the combination of the box splint plus minus backboard. I think that's a pretty effective way to immobilize distal femur and knee injuries. And then if you think there's something up by the pelvis or the hip joint, your backboard or even your sled does a not too shabby job of holding that still. Pete, I hope I answered your question without being too evasive or politically correct.
Mostly, thank you.
Any more questions for Mike? Let him get back to the patient who's dying on the table.
Yeah, they're doing CPR back there right now.
Thanks a lot, Mike. That was a good refresher.
All right, you're welcome. I guess we'll see what other topics are of interest and adjust things as you guys want.
Yeah, I appreciate it, Mike. Thanks for taking the time out of the day, and we'll see you over. Have fun at Stratton this week. Hopefully
Thanks.
it's lunch for you.
Thanks. Hope to see you guys soon.
Bye-bye.
Bye.
Daddy,
All right. So let's roll into our meeting here. Most of you guys got the email from today, hopefully. So there's a bunch of